and good morning to those who are not located in New Zealand. Well, welcome everyone to our first webinar series of 2017. My name is Tanya Peters and I'm from the Safe Communities Foundation New Zealand, and along with Tracy Earle we are your hosts for this webinar. Apologies from Megan Brotherton from Australian Safe Communities Foundation, who is currently en route to Melbourne. Now, just before we hear our presenter this morning, just a few housekeeping matters. We've got a fantastic presenter lined up today and we do have time for questions. We want this to be interactive, so please ask questions. Each participant has access to the GoToWebinar control panel on your screen, so just take a minute to familiarise yourself with its features. If you're having any problems, please send us a message via the control panel and we'll endeavour to resolve the issue. You can ask a question during the presentation. You can type your question area into the control panel and we can answer you there, or we can read it out. Or you may wish to put your hand up. You can click on the yellow hand control on your control panel. If we can't answer your question, or if there isn't time at the end, we can answer via email. This webinar is being recorded and will be available for viewing early next week. Now, I'd like to introduce our presenter, Dr. Rod McClure. He's a public health physician and injury epidemiologist with 30 years of experience in injury control that covers the research and practice continuum. Now I'm going to hand over to Rod, who's going to present on injury prevention as social change. Over to you, Rod.
Thank you very much, Tanya, and thank you to you all for this opportunity to chat with you about a topic that I'm sure we're all commonly interested in. I think I'd like to undermine before I start, though, any notion that this is an expert presentation. You'll be amused when we get halfway through this that you'll find that what I'm talking about sometimes is new knowledge, beliefs and practices that you've been using and developing for the last 20, 30 years, while other colleagues of yours have been running down other paths thinking that they had the right answer. I think this talk, to some extent, starts off with the authorised version of injury prevention and then moves into a type of injury prevention with which you're much more familiar. And what I'm hoping to do over the course of the next 45 minutes is provide an underpinning of concept, perhaps a little bit of theory, perhaps a little bit of justification on the basis of the literature for some of the work that you're already doing, rather than coming up with some ideas that I want to tell you about that I think are new. The one thing that strikes me always when I'm approaching a new topic with people from different disciplines is that if we start talking about the how, if we start talking about our belief systems, our foundations for knowledge, we get very quickly bogged down and we tend to disagree before we get anywhere. If, on the other hand, we start talking about where we want to go or what our goals are, then we find there's a much clearer and a much quicker agreement and consensus reached. Most of us have a sense of what we're trying to achieve, even though we try to do it from slightly different perspectives on many occasions. So I'm starting this talk with the notion that, and it's a premise which could be discussed in itself, but for the sake of this talk I'm starting with the notion that the goal of injury prevention research and practice is to reduce the population level indicators of injury-related harm. That's the morbidity and mortality in a population that you count in frequencies, that's where we're trying to reduce. And if we're trying to reduce that, then we're immediately shifting into this notion of how to get population level change, because it's not individual risks we're dealing with, but frequencies or number of mortality and morbidity that we count at the population level. And just taking some data from the United States at the moment, because that's data I have available, at the population level, the information's telling us that we're not doing really half as well as we might think we're doing if we get our positive reinforcement from specific pieces of work in specific parts of the condition in specific parts of the country or specific parts of the world. Now, you'll have data that you're used to looking at that represents either your community or your country. New Zealand, for instance, will have data that's a little bit similar in some respects, but different in others. The big success story in injury has tended to have been the motor vehicle crash injury reductions. And if you look in the US at the transport-related deaths between 1999 and 2014, they flatline up to about 2007. They drop a bit to 2010, they flatline again, and they're now going up. Falls are going up, and they're going up in Australasia and Pacific as well. Poisonings are going up dramatically in the US, largely because the prescription drug overdose problem here is more significant than in the other countries in the world. But we've recently looked at the Australian deaths data, and there's an increasing prescribing practice in Australia as well. I haven't checked the New Zealand prescribing, but in the US the increased deaths tended to be correlating with increased prescription opioids prescriptions. Homicide is going up in the US in the last couple of years. Suicide has been going up for a long time. So these are the sorts of things that we'd like to bring down. Now, in some of these lines, they are going down in Australia. Child injury tends to be going down as well. That's not listed here as a subpopulation, although to some extent a lot of that child injury related deaths is because of the successes in road safety. So not that I want to actually say very much about these directions, but I just want to say something about the fact that we need to look at this bigger picture if we're trying to make some meaning of what we're doing in injury prevention. Unless we're doing something about these population indicators, can we really say we're succeeding as public health injury prevention practitioners and researchers? Now, in the past, it's been well recognized that injury is a consequence of a complex web of social, economic, and environmental, criminal, behavioral factors. William Haddon himself talked about injuries as an ecological phenomena. But you can see in both these quotations, and the one from Presley is the Injury-Free Coalition for Kids, which is a similar type of injury prevention perspective to the one that is held by the Safe Communities, but not quite, because it's a hospital-based initiative, the Injury-Free Coalition. But both of these quotations slip from a complex understanding of how injury is caused to a systematic explanation for how they feel one should be doing something about the problem. Now that, I think, is the anomaly which has caused, to some extent, our inabilities to make big differences at the population level in the terms of injury over the last 30, 40, 50 years. There's a disjunct between the complex nature of the problem and the systematic or reductionist way that we've focused on solving the problem. Now, I'll very quickly slip through 5 or 6 slides which, in my mind, explain why we've gone down the systematic path and the difference between a systematic approach and the systemic approach. Getting back to the title of the talk, ultimately where I'm heading is that if we want to solve the problem of injury at the population level, we need to be looking at social change. And social change is about the whole system. It's not about trying to find an isolated broken part and fixing it. And I can talk in a little bit about why the systematic or broken part approach to addressing the problem produces perhaps less effective solutions in the long run. Even though if you define a very limited goal, circumscribed scope of evaluation, you can show that there are some benefits in the systematic approach, and it's those benefits which have tempted us to take that particular approach as our sole modus operandi. There are many sort of truths, many worldviews. This is a history as I've written it. There's some support in the literature for this, but yes, you might want to look at the literature and come up with a slightly different explanation. But this is an explanation which brings us to where the orthodox view of injury prevention currently sits, and I'm saying that as somebody who is certainly not speaking for the CDC. This particular presentation is not a presentation from the CDC, but I have looked at the way the CDC understands injury, and it still understands injury very much from the classic public health approach to injury prevention model, a systematic approach. And it grew about 30, 40 years ago from a culmination or a coming together of an engineering discipline, which, as roads and motor vehicles were being built by engineers and energy was being understood by engineers, they realized that they could actually control that energy through the same sorts of processes that they could create it. Pediatrics independently was coming up with ideas about ensuring that the early childhood experience where children developed capabilities and capacities at different points as they developed were not limitations that put them at risk, that they were exposed to environments which were accommodating and forgiving so that children could grow in the context of their different capabilities and still end up being safe from harm. So this was the notion of an external environment which was protective and safe. And at the same time, occupational health and safety through a number of initiatives, the Robins Initiative, for instance, in the UK, was starting to come up with some notion of regulation and a responsibility of workplaces to maintain safe workplaces and to regulate behaviour so that that safety was generic. This led on to an energy control mentality, passive versus active mentality, regulation mentality, and it tended to push the disciplines like sociology, psychology, community psychology, behavioural sciences, human factors, a little bit to the outer. And there were some quite strong papers early on in this about accident proneness and how thinking about accident proneness was an anathema and something which should be banished from the rhetoric of the public health approach to injury prevention. This systematic approach became even more obvious over the subsequent years as risk factor epidemiology was developing about the same time, where we used statistical analytic tools to extract the independent effect of certain risk factors controlling for the environment. Clinical medicine was focusing more and more on evidence-based medicine, and I'm talking very recently really in the scheme of things. I still remember the advent of evidence-based medicine coming through in the 1990s, and this led naturally into this notion of evidence-based public health, where evidence was something that could be identified through randomized controlled trials. And largely I think these sorts of trials is more about a search for certainty rather than is the search for evidence. The validity of these studies were able to exclude the threats to validity and provide greater precision around certain pieces of information. And even more recently we've been talking about precision medicine, and there have been papers now published on precision prevention where we tailor our prevention processes to the individual risks that an individual might face compared to another individual within the same sort of general category. So this is where we've been heading in the classic evidence-based systematic way of identifying broken parts and fixing them and replacing them. The problem with this, though, as you're all aware, is that it leads to a left to right linear sort of thinking. Now, and I say you're all aware because there have been some very good papers published by people from your own disciplines, Hansen as an example, from the safe communities, who've taken this on and said there's something wrong with this model. The model, though, is still advocated by the establishment largely. It begins on the far left at the bottom to suggest that surveillance provides you with an account of the size of the problem, the nature of the problem. The risk factor identification is then something which is done using such tools as modern epidemiology to identify those aspects of, and it's often the proximal environment around an immediate injury risk that can be isolated out of its context, that countermeasures, and this is the intervention development, countermeasures can be identified to counteract that risk factor, often an energy exchange, that those countermeasures can be rolled up into a program with a specific target group and then scaled up, and the results of that evaluated and monitored using the surveillance, which closes the loop again. So one of the problems with that that's been identified is that that area on the left of the orange bars is often done in research environments. The work on the right is often done in the real world, and there's a piling up of supposed knowledge behind that barrier and what people call a research to practice block. In fact, the whole idea of crossing that block and the various mechanisms for doing so has become one of the major foci of both researchers and practitioners. And while the linear left to right research to practice pathway exists, we've had a lot of trouble doing much about addressing that well-recognised issue. We started off translating knowledge to practice, and the word translation indicates the extent to which you've got to take a language from one area and turn it into another language before it's actually understood. In many cases, this was using information brokers or shouting more loudly or being at more meetings. Dissemination and implementation science also developed as a sub-scientific discipline of its own, where this was a case of trying to identify the facilitators and barriers which prevented the uptake of what appeared to be the evidence on the left, being widely disseminated on the right of that linear pathway. Adaptation was another approach that was started to become more popular when people realized that the dissemination implementation science really wasn't achieving its potential or its ideal result, where in adaptation we no longer expected an absolutely faithful implementation of a research program that was created in a laboratory, because in the real world it isn't a laboratory, there are real world needs and necessities, and that the essence of those programs can be maintained while still adapting the ways in which the uptake is achieved. Hence the program was expected to be more palatable and more implementable and therefore more effective. And more recently still, perhaps, there's been a recognition of injury prevention using the knowledge of public policy to try and understand how dissemination of science takes place. And that it wasn't simply a case of going left to right along this linear pathway, but you could stay, yes, within the general rhetoric of this linear pathway, but sit on the right side of it and pull information from the left. So that you started in the real world, and you started with the public recognition that there was an injury issue of importance, that if you combine this with political will to get something done, and the third element, a well-developed evidence-based policy that was just sitting on the shelf, then you could take advantage of this window of opportunity that had been created and bring these three things together and achieve policy action. So this is the conceptual model of Kingdon, his windows of opportunities model or social policy model, where he said that policy moved forward in these sudden leaps when you were able to achieve this convergence of the three components, and that the role of practitioners was really to look for opportunities where they could bring these three components together and perhaps encourage these situations, that open these windows where you had something like what's called an outrage event that you could use to generate awareness in the public that this was a problem, and that with some advocacy that you put in place argued that there were political benefits and no disbenefits for politics in all of its forms to buy into this issue. And then if you had an evidence-based policy that you could slap on the table and say, this will answer the problem, this will address the problem, this is what you need to do, this is how much it's going to cost, and this is what you're going to get back for it, then you'll get some intervention. Now, even at that point, though, I will say you don't get the right intervention, and it still leads to a quick fix mentality that comes from this fix the broken part approach. The limitations of the evidence-based evidence-based public health approach are that it reflects one discipline, and I'm really scooting through this quickly because I would like to put out all of these contentious ideas and have an opportunity at the end for discussion. I see we've done about 20 minutes, so I think the other 20 minutes of the 40 will be spent explaining the alternative, the systemic approach, and we can discuss how that might be what you're currently doing already but don't have the words for, or work that you're currently doing that you think illustrates this in a definitive, concise way. The limitations of the classic evidence-based public health approach is that it reflects just one discipline. It expects risk factors to be able to be isolated from their context. We know we can't do that. Effects of these are quantified in evaluations holding all else the same, and you can't hold all else the same in the real world. If you're trying to do evaluations, you can't adopt the classic evidence-based approach because the real world is changed by the intervention. And the world is actually using component parts that are well beyond what can be reduced to a controlled trial. The parts that are evaluated in randomized controlled trials are only small parts of an actual intervention. Requires social institutions, social structures, social capabilities, really in order to bring those component parts to practice. And it's those social institutions and social structures and social histories and social contexts which are as much part of the intervention, I'm arguing, as the reduced components that are ever evaluated in RCTs. The notion of a population as your patient is a critical one. Identifying the results of the population just simply as a sum of individuals doesn't work, and focusing on trying to affect individual risk behaviour instead of collective risk behaviour neglects the fact that it's the between-person risk factors and the way that we organise our structures that are actually the drivers of the large proportion of the risks that are all faced, not necessarily the risks that can be measured at the individual level. So if we want to make big changes and big differences, we've got to change structures, not behaviours. Except that behaviours will necessarily be changed as a downstream consequence of the structural changes we put in place. Now, the essence of the systematic versus the systemic approach is the recognition that the world's problems lie on a spectrum between highly technical at one end and highly adaptive at the other. And I'm using these terms here in the context of learning theory, not necessarily saying technical equals technology, but technical equals those sorts of things which break, for which you can bring in an expert and replace a part and fix. Adaptive challenges are those which are difficult to identify even as challenges. People debate what the real challenge or the real problem is. They require people to change their values and beliefs in order to understand or address the problem. The people who have the problem really are the ones who have the power to control it, that no outside expert is identifiable, and certainly no outside expert has the authority to work in the space that needs to be worked in if these adaptive challenges are to be fixed. And in many cases, we don't even have the answer. We need to continually work and evaluate and apply and reconsider through a process of disciplined inquiry and ask ourselves, what are we doing that's making what sort of difference, and what can we learn from that so that we know what we do next. Injury epidemiology has tended to work around identifying the broken part as if fixing that is going to solve the problem. The fact that we can't even reduce road safety in large high-income countries like the US means that there's a lot more to the problem than simply the seatbelt. And this is all material that's not new to you. You're probably the audience that least needs to hear what I'm saying at the moment, except perhaps to provide you with support and confidence that what you've been doing actually is now starting to be heard by people in places where I've been working. We need to develop a better and better understanding of the structures that explain the behaviour of the system, and we need to work to change the system so its outcomes become closer and closer to those which we prefer. The diagram here, it's not really necessary for us to go into it, but it's a replacement diagram for the left to right linear model. It's arguing that the systemic approach needs us to think in systems. It needs to go through a collaborative, adaptive inquiry and action, adaptive action, keep changing what we do, looking at the result, and we need to develop the science to support this approach, because the science that we currently privilege is not the science necessarily that gives us the complete answers to our needs. And that if you combine these three things in an ongoing interrelated way, I'm arguing that we'll end up understanding and taking on board and achieving a systemic way of doing business instead of the highly reductionist way that we've used in the past. Now I'm going to go through 3 slides here, one talking about what's a system, one talking about what's collaborative and adaptive inquiry, and one talking about what's the science that we need to learn. So a system can be reduced, I think, simply just to 3 dot points. They're elements, they're things, they're components. The second thing is that there need to be relationships between these elements, and that these elements and the relationships between them can be defined in a way that allows them to be achieving a purpose. And in some ways that's the issue of boundariness. It's putting a bound around things. So what is the goal? What's the function? What's this thing trying to achieve? What are the parts in there that work towards achieving this? And what are the relationships between the parts? Now, systems can be simple, and these are the sorts of things like your television breaks down. That's a technical problem. That's a quick fix problem. You bring in an expert, they change it. It's not the fact that I can do it, but I just know that there's something that's broken in there and someone can fix it. That's a simple problem. If it's not just a television, it's a massive computer, yeah, it's a complicated problem, but it's still technical in the sense that we can get an expert to spend a few hours working through it, diagnose the problem, fix it, and they'll be back on the road. The complex and chaotic, though, are different. And I'm going to focus on the complex because the chaotic is beyond really the scope of what we're trying to do. It's the complex systems which are the systems that define society. And the complex systems have several characteristics. They have a function that comes out of the system working in its entirety. You can't just look at it apart and know how the system is going to work. There are multiple elements in systems, lots of them generally. There are subsystems in them. There are levels, so that you've got macro systems, and you can think here of macroeconomics or microsystems where you've got households inside that. And if you try and look at your system, all of those different levels of the system operate together somehow. And even within bigger systems, you can generally find subsystems which operate to let's say a family might be a subsystem inside a larger system of a social community, a regional country town, for instance, which might be a subsystem inside a national economy. So understanding that there are lots of moving parts, they move together, they don't move in a linear fashion, there are feedbacks between them, that the parts don't operate on their own. If something happens, then quite often something else necessarily happens because of the connectivity between the various parts, and how the network is defined very much determines how that system will operate. Even if the same elements in that system can be found in some other system but have different networks, then you might find those two systems operate differently. And you can now start really, before I get much further, to recognize the challenge that the translation and implementation science people have had when they've tried to take something out of a box and plug in and play it in a particular community. The other thing about the systems is that they tend to be self-organizing, they adapt, they have an autonomy. And here I'd really like to highlight, because if we're trying to talk about social change, it's the one thing that we all recognize about societies, is that they control themselves, largely from internal forces, but sometimes they're affected by external forces as well. And their reaction and the way they adapt to those external forces is part of the resilience or part of the nature of that particular society. But those of us that lose heart when we say, well, it's much easier to control specific broken parts. We know what to do there. We can define that. We can tell our funders that it's going to cost them X to fix Y. We can't do much when everything's connected to everything. I think need to take heart, because we don't say that about our society. We know our society is absolutely everything, connected to everything, but it is grown, it's evolved over thousands of years with inbuilt control systems and response systems and management systems which allow us to control our society. Those are the very systems, the very nature of society which makes me feel that we can control injury in the same way we can manage the rest of our societal outputs. In fact, if society are a group of people who've come together to improve the collective well-being, otherwise we'd still be back where Hobbes left us, then all we need to do is define injury outcome as part of our social well-being, and we have injury prevention absolutely located in the heart of the justification for why societies exist. Injury prevention isn't something done on the side. It isn't something which gets in the way of business. It isn't something which interrupts people's freedoms. Injury prevention is in fact the reason society has created, and society has the capabilities to ensure that we become more and more structured to become less and less affected adversely by the adverse consequences of this thing we've previously defined as the other, that thing called injury. Systems thinking is a way of approaching challenges in which we consciously seek to delineate systems of interest, expand our field of vision about causes and consequences, describe structures that underlie the relationships in society that are leading to the frequencies of mortality and morbidity that we're measuring. Systems thinking forces us to use qualitative and quantitative models of how society works, and to force those models to explain themselves, and to force those models to force us to be explicit about the assumptions that we're making about how society is working or how the system is working, and to explore the behavior of the system that follows from its structure. And then play with those structures, and I can argue we can do it through now simulation using the technologies that are now available to computers which weren't available to us before, so that we don't need to isolate the individual risk factor out of context. We can actually play with the entire modeled system and look at what happens when we change some part of it and how that change ripples through the system to affect the outcomes that we all agree to be of our interest. Once we're confident that we understand the system, we can go about making the changes, and we can then watch what happens when we make the changes. And we become less and less wrong about how we understand our system. I don't think at any point I would ever say we can model society, we know what's right. I think during this talk I started off by saying I'm not presenting anymore as an expert, but as one of all of us trying to explain what we are, and on the benefit of that examination make decisions which help us become less wrong rather than making decisions which we know are evidence-based and pronouncements from experts which we all must put into place or else. And this is the collaborative adaptive inquiry. I think research is with, not on. It's, as you've been talking about before, participatory research is the vital element of this adaptive learning. Learning is not simply changing our behaviour, it's changing our mental models about how we understand structures, and in many cases you could go as far as saying it's changing our perspectives and our values. And it's until we start to examine those, we're not really going to get the changes in society that are going to lead to the major results that we're trying to in terms of the population level injury outcomes. And this is not heresy in even the medical literature, because the learning organisations are now being started to be talked about inside medical systems. It's just that we're not restricting this conversation to particular health systems that are well defined. We're saying that we need to extend this learning organisation model throughout public health and throughout all of those things which create the social determinants which are producing our problem. But it does mean we need to take the science head on. We need to question our current paradigms. We need to start to push our current expertise to its limits and come up with new scientific expertise. We need to bring the disciplines that are not yet prevalent in injury prevention but are prevalent in the rest of knowledge and scholarly academia more into a privileged place in injury prevention. And we need to find some way, and I've used the term transdisciplinary public health here. I'm not quite sure I believe actually in transdisciplinary public health so much as pluralistic public health, in a more pragmatic way, where we use the knowledge that we need to use to help us answer that component of the issue at the time, and where we need to use other systems or other disciplines, then we use those. I don't think anything I've said undermines my core quantitative background. I'm very much, at least started very much a classic medical model epidemiologist, and in many ways that's still my comfort zone. But I've moved in more into complex systems, agent-based modelling, systems dynamics modelling, because I was recognising that there were more questions to be asked and there were solutions I wasn't being able to achieve using the particular disciplines that I was using. Not to say that those disciplines originally aren't useful in the bigger mix. So how do you facilitate? How do you actually do this? In the last 7 minutes I want to go through 7 steps. First, and this is a linear approach, which it's a reductionist approach. You can see I'm revealing myself a bit here because in many cases you can talk to systems thinkers and they will enjoy the process as much as the outcome, perhaps more than the outcome, and they will talk about the interconnectedness of all the things that I'm just about to be talking about. But me, a reductionist at heart, I've boiled this down to 7 steps. It's a list, and it's a list that I'm going to say we need to iterate. But that's for communication purposes to some extent, and for putting the ideas on the table, and for saying that just because it's complex, it doesn't mean it's all too difficult. I think it's all actually remarkably simple, and it's incredibly important. And some of it you'll recognise, and I've just put different language on. But even before we identify what the problem is, we need to engage the stakeholders, because it's only by talking to the stakeholders that we'll get clarification on the nature of the problem. And you can do this formally. I don't think just because we're bringing in complexity we should drop formality. There's a rigour that we need to be doing. Now the rigour won't get us expert fact, absolute truth. The rigour will help us though move away from error more quickly and become less and less wrong more efficiently, effectively. This isn't an anything goes approach. This is a highly rigorous approach. But we need to find out from the stakeholders who they are, who owns this territory. There's not much point us sitting as public health practitioners in a room saying everyone should listen to us. We actually need to have everyone in the room who's actually got responsibility and ability to change things. And we need to find out what their issues are and where they want to head. And we need to analyse the what and why and how of us all, and then the who's missing, and get them involved as well. So there's very much a stakeholder engagement. Then we need to help all of us better understand the systems thinking approach, because most of us don't think like that. At least we do in the car park, but we don't when it comes to work. For some reason we change hats completely. We need to understand how one does collaborative learning and do the personal growth that allows us to be good conversationalists rather than entrenched us against them thinkers. We need to develop not only the personal tools but also the technical tools, and I dropped a few names then. There are lots and lots of methodologies around this. Systems dynamics is a quantitative one, agent-based modelling is another one, soft systems thinking is another one. There are lots of things that will help us. They're really just tools for thinking so that our thinking will become more rigorous. Because I think the basic science that links all of these methodologies together is conceptual rigour and conceptual honesty, and being able to examine an argument and see through it and see its strengths and see its weaknesses and have the tools with which to test that argument. And that's, I think, what we can all agree on, even if we might not agree on the particular disciplines that we're coming to the table with. I think the participatory model building exercise is really functional. It helps us get a common mental model to challenge that, to question the way we think the causal relationships are in the bigger picture, in the system, in the society. What goes with what? What leads to what result? And we'll never know when we sit in a room whether we've got it right, and that's why we need to bring in some of these analytic tools, because complexity is by definition something that our cognitive pathways can't grasp. We have a RAM of about 7 thoughts. We can hold them in our head at once, and if we've got more than that, one of them has to drop off and be replaced by another and to be brought back out of memory. You can't imagine, once you've got a dozen or so critical elements, all reacting with feedback loops, with nonlinear influences, how that's all going to function. So we need to model that to see how it will function. We'll test it in computers, on paper, conceptually just with our colleagues to start with, but ultimately test it by putting things in place in the real world and watching it. It's just that it's a lot more expensive. It takes a bit longer to put it into the real world and watching it. But in things with short-term turnarounds and in smaller scope, you can do that. You can get feedback from the real world. But there are tools which will help us run simulations in the meantime. And then the final 3 aspects of this, which are not trivial, is that you identify points in the system where interventions can result in maximal benefit. So you're looking for leverage here. Everything is connected to everything. It is, if it's bigger than Ben-Hur, hard to grasp in one intervention, but you can find the wolves in Yellowstone Park, which, when you introduce them, can have downstream ripple effects that change the direction of rivers. We can go in and change society. We can go in and make a big difference for long-term outcomes in complex systems. If we understand the system, we know where to pull the levers, and it's pulling the big levers that we want to do. It's not just fixing the spark plugs. We can only do that, though, when we get agreement by those people who have some jurisdiction over the levers, and I'm now talking about individual citizens as much as talking about people with political operations that they manage, because by and large they operate as a consequence of the citizens' will in the first place. So there really is an interrelationship between all of the players who own parts of the system and are part of the system, and how they work together can help drive the system as much as it does drive the adverse outcomes. And we need to be continuously updating our problem definition, our causal diagrams, our analytic simulations, and we need to adapt our solutions accordingly. This isn't put in a solution, wait 3 years, evaluate to see what the difference is, find out we've got a 20% improvement in one group versus another. This is a case of taking the results that we know from those trials, sure, but putting them into work in a way that actually creates big social impacts, and looking at the effects of what's happening when we put these in, and looking at the barriers, and looking at what's working, what's not, trying to understand whether we've understood the structure of the place that we're working. Because it's the structure which really is the element of a system which determines the behaviour of that system. And through this process of collaborative learning, adaptive intervention, the system will shift little by little, more and more. Hopefully it will shift in the desired direction. And we've all seen situations where systems have moved in the wrong direction for various reasons. But our process of discipline inquiry, adaptive learning, using all of the science that we have available, all the evidence that we have available, recognising evidence comes in multiple forms, recognising that we don't want to play around the edges and tell the world what needs to happen. We need to work with the world so that we're part of what happens. Then we'll be able to get that result we're after. We cannot sit back and say, well, the system is broken. I don't think the system is ever broken. And I've been trying to find the source of this. Northrop and Highfares quote it, but I'm sure they weren't the originators of this. A system is perfectly designed to produce the results it gets. If we don't like what the system is producing at the moment, let's go back, examine the structure of the system, and change the system so that it works in a different way. But if it's producing this sort of result that it's getting at the moment, then it's being driven by some good for somebody, and it's being encouraged to drive in this direction. And if we don't like the adverse consequences, then we need to go back and provide the incentives and pull the right levers and create the changes we need to change so that these adverse consequences that we're currently finding are not the ones that we have to live with. Back to you, Tanya.
Well, thank you very much, Rod. That was a fascinating presentation that you did, and I always enjoy listening to you and the ideas that you present there. I'm just going to hand over to Tracy to see if we have any questions. So if anyone has any questions that they would like to ask of Rod or any thoughts, please either raise your hand if you would like to speak and ask a question, or you can type it into the box. So Tracy, do we have any questions?
Yes, just one moment. We have a question from Michael Mills.
Here's my question. Where do I write it?
You can just ask the question.
We can hear you
just
now.
ask.
Yep, you can just ask.
Oh, okay. My question is, what is the lowest level in an organic sense? What is the lowest level to which you can define a system? Could it be a neighbourhood, a street, a community, a distinct, I'm talking in geographic sense, or are we talking national, you know, whole of the country type levels? You know, to what level can we go down to define and still be working within a system?
That's Robert Mills, is it? Yeah, you've landed on one of the defining questions of systems thinking, and it is tied up in this notion of a boundary. If everything is connected to everything, where do you actually stop connecting things? And where do you work within and say, these are those that are endogenous causes which affect each other in this causal set of loops, and to what extent is this affected by some exterior factor over which we have no control, we're not interested in discussing. And the answer to your question is whatever you want it to be, and that answer is an unsatisfying one for you. But you could have a system which could be as big as the household when you're sitting down collectively trying to work out how to manage the issue of skateboard injuries or whatever it happens to be. Now, there may be more effective ways of defining that boundary which will produce a safer household than simply defining that boundary around the household itself. And that's the discussion which is part of the early stakeholder definition of the problem, when they also need to define for themselves where are the biggest levers that are affecting the outcome of interest in this group sitting, and those big levers by and large need to be sitting inside the way you define your system. But if you wanted to be technically pure, you could define a system pretty much with 2 or 3 variables, as long as you related them together and showed that they were commonly working towards some purpose.
Yep, thanks.
What's the useful way for you is the answer, really.
Yep, no, that makes a lot of sense. Thank you.
I'm sorry, Tracy, you've still got yourself muted. Can you unmute yourself?
My apologies. We have a couple of questions that have been typed in. One here from Jonathan Jarman, who asks, where does community involvement fit into a systemic injury prevention solution?
Yeah, right at the heart, which is why I think I was trying to get across earlier on that while injury prevention experts have tended to drift away quite early on from community-based injury prevention because they felt they could sit outside community with policies or regulations or technical fixes, I think you've only got to look at how poorly we've achieved true injury prevention results over the last 20 years to recognise that you can't afford to leave community out. The community actually are our society, and even community leaders and decision makers are only there at the behest of the community who've actually given them the political mandate to work. So the laws in the US which were brought in to make helmets compulsory is a wonderful example, and then thrown out again because the legislators were voted out of office because they brought them in, is a wonderful example. If you can't isolate an energy control intervention like a helmet and expect to just drop it in and ignore the fact that it has to be dropped in the context of community. Community have to be part of the conversation as to what's acceptable. They have to be part of the conversation of what the problem is, and they have to be the people who authorise those externalities to actually put in the regulations that might be required. I'm sorry I take a long time to answer questions because I find them all so interesting, but if you try and reduce the injury death rate on the road in Atlanta, you can give responsibility to an individual to reduce their own, or you can say the individual really has to buy into reducing their freedoms, so they need to authorise the legislators to restrict freedoms universally so that the roads can become safer, so that as an individual on the road, they run a less risk. Now that's a lovely relationship about community responsibility, collective responsibility versus individual responsibility. That is one that the community can't be left out of. But if the community understands it, then the individuals in the community will be better off.
Thank you for that. Rob, there's another question here from Teresa Stanley who asks, says you talked about analytic simulations after implementing an intervention. Could you please explain how to do this in the real world?
Yeah. The simulations are generally done as hypotheticals, and there are now wonderful analytic tools which allow you to represent that part of the real world that you want to examine in models and then change the policy in the model and see what happens to the result. So that's where the word simulation is normally used. Where in the real world simulations are done, they tend to call this adaptive learning. There's another term which has slipped my mind at the moment, but it's the innovation model that business does all of the time. They make a small change. If it works, they do it again and make it a bit bigger, and if that works, they make it a bit bigger. If it doesn't work, they haven't invested too much in it, they can drop it off and try something else. So test, rapid prototype, test, scale up or reject, and then throw seeds across a big range, so you've got lots of people coming up with lots of these ideas and only the strong ones will survive. That's simulating really, but in the real world. And it's a little bit harder to do in public health because, as we know, things like smoking, and it takes 50 years sometimes to get the real changes in the social structures that we're trying to encourage or the cultural shifts. So while you can do it, you can certainly do it in intervention. There's a good example if you want to look it up. In the US, there's the COIN, the Department for Health Services, HRSA, Health and Community Services. They're doing some COINS, C-O-I-N-S, all in capitals, and they've written it up on how they're doing this rapid prototyping model for injury prevention in children. And that's what I would argue would be the real world simulation.
Okay, thank you. And the last question here from Sue Ramsey. She says, a fantastic presentation. Her question is, her observation is that the model seems to be driven by science rather than practice. And there's several questions here. First of, is there a place for it to be driven by real life experience or discovery? Is there a place for practitioner or community voices? And is this place essential or peripheral?
Yes, you're quite right, and what you've identified is more a limitation in my presentation than actual limitation in the ideas that were there. I have this discussion here quite a lot with somebody, well, in the CDC. They're really practitioners, and they're arguing that practice-based knowledge is what I'm talking about here, and I agree with them every time they raise that. So the fact that I haven't got that information across to you is just because, as I say, I come from an old world thinking where I sit in, by and large, the research comfort zone. But this is an approach which allows practitioners to do practice and learn from it. and the rest of us learn from it as well. So it's practice-based science, and it's not a case of, I know this has been talked a little bit about from left to right where you translate from research to practice, and it's sometimes been talked about practice to research. I would argue that that circle no longer distinguishes between practitioners and researchers. I would argue that the practice of science and the science of practice are absolutely integrated into the same thing. They're just two sides of the same coin, and that practitioners are as much scientists as scientists are practitioners if they adopt this model. Not sure if that answers your question.
Thank you. I'm sure Sue will be in touch with you if she needs any further clarification. So that is all the questions we have for today. I'll just hand over to Tanya.
Well, thank you, Rod, for presenting to us today, your evening, and taking the time to share with us. I'm sure that everyone got a lot of information out of that presentation. Please feel free to email us at the office if there's any questions. We can collate them if you think of anything else and forward them on to Rod. And also a reminder to please fill out the survey at the end of this webinar to let us know any other topics you would like addressing, or any feedback is welcome. And just to remind you, the reminder that this webinar has been recorded today, and there'll be an email sent out to all participants next week where it'll be available to view online on the website. So thank you everybody for your time today, and we will listen and see you all again in April. Thank you.